Sialolithiasis is a condition involving the formation of stones within the ducts of the main salivary gland. It can be in parotid, submandibular or sublingual gland. The clinical features are pain and swelling in the affected salivary gland, of which the pain increases when the salivary flow is stimulated. This is also called as mealtime syndrome. The salivary calculi is a hard, stone-like concretion that forms within the gland or the duct. The contents are mostly inorganic and organic salts. Lack of saliva or decreased salivary flow will be an important sign and symptom of this condition. There may be erythema of the floor of the mouth and pus discharge of the gland if the gland is infected. Cervical lymphadenitis and halitosis also may be present. The investigations for this are ultrasound, sialogram, or you can go for a computed tomography. This image shows the axial view of a salivary calculi in the submandibular duct region. So the management would be surgical excision of the stone within the duct. If the stone is within the gland, the other option is to do a lithotripsy or excision of the salivary gland. So now we can see the procedure for the excision of the submandibular salivary calculi. Bilateral lingual nerve block can be given and the floor of the mouth can be infiltrated, and you can palpate the swelling or hard swelling over the floor of the mouth, and you can place a incision over that hard swelling with a 15 blade. Before placing the incision, remember to get a stay suture. A stay suture is held posterior to the hard swelling so that the stone doesn't slip posteriorly. And then you start, after your incision, you can start dissecting the stone, and you can use a sharp dissection initially where you can dissect the stone and try to expose the entire stone. So now you can see that stone is being dissected in and around circumferentially with the dissecting scissors. So you have to be very careful when you are doing on the floor of the mouth, because the lingual vein will be very proximal to the structures in the floor of the mouth. So what are the structures in the floor of the mouth? You have the lingual frenum, lica fimbriata, and the lingual vein. So never try to crush or hold the stone firmly. If you try to do it, the stone will crumble, because it's only salts which are multiple concretions which forms a stone. So never try to hold the tip of the stone, because that's going to be a weaker point and it will start crumbling and it will start coming in piecemeal. So start dissecting bluntly again without injuring the vital structures in the floor of the mouth. So now I have just switched on from a sharp dissection to using a mosquito artery forceps, and each and every time I'm trying to see to that the stone doesn't dislodge posteriorly. I'm trying to pull the stay suture up so that the stone will be pushed forward. So now you can see the opening is made slightly wider so that the entire stone can be taken out in one piece. Hold the stay suture firmly so that the stone doesn't get dislodged posteriorly. So it is very vital to get a proper plane between the stone and the soft tissue, and especially try to get access to the posterior aspect of the salivary calculi. By getting access to the posterior part of the salivary calculi, you will be able to relieve all the tissue adhesions. At the same time, you will be able to push the stone from the posterior aspect anteriorly. So that is what we are trying to do right now. You can see I'm just trying to get access on the posterior aspect of the stone and trying to push the stone anteriorly. At the same time, the stay suture is also helping us from the stone not moving posteriorly. So now the stone is again bluntly dissected with the mosquito artery forceps. Circumferentially, you are trying to free the stone. So the stone, it's almost 4 centimeters in length, which was measured in the CT and excised. So you can see that's a 4 centimeter stone. Once the calculi is removed, the wound is irrigated with normal saline to flush out all the smaller particles. And now the wound is sutured with a 3-0 silk suture. Ideally, it will be better to place 2 simple interrupted sutures, and it is post-operatively it is better to remove it on the 2nd or 3rd or 4th day, so that there is no stricture in the salivary duct. It's a 1 week post-operative healing.